So this is the endophthalmitis management. Everything has been said about the diagnosis and the investigation. So we will not waste much time about that thing and go straight into the management. So only one, this is important. Why it is important? Because it's a loss of vision, loss of reputation, and also medical legal problems. And acute, when to suspect and what to do. So as Dr. Rajesh already went through the symptoms, I am not again going through these slides and incidents and what you look for. Then it is also the earliest retinal findings, also elaborated. Then ultrasound D scan 48 hours before and after vitrectomy. And progressive vitritis is the hallmark of any type of endophthalmitis. So now we come to intervention. So intravitreal antibiotics covering gram-negative and gram-positive urgently, and TAP for stain and culture and PCR as explained by Dr. Indu. And topical antibiotics 1 hourly we give along with mydriatics and topical steroids if cornea is not involved. Also intravitreal antifungal we give if KOH smear is positive. So intervention is correction of wound leaks, suture abscess, vitreous incarceration, eroding scleral sutures in SA5L and other surgical problems. Then also along with it, systemic antibiotics, which is questionable, but we use 4th generation fluoroquinolones. So at presentation to the post intravitreal steroids, the role of steroids in intravitreal antibiotic along with intravitreal or systemic, there is some topics of discussion. But after intravitreal antibiotics, steroids definitely have a role to decrease the inflammation and to save the eye. And also systemic recommended, not in fungal initially, but in cases of fungal endoph and in case of diabetics, we don't give systemic steroids. And topical also we don't give if cornea is involved. And intravitreal steroids in case of fungal endoph also, there are some conflicting reports. So what are the improvement signs? Those are the pain decreases, cornea infiltrate stabilizes, AC exudates are less, sounds shows better results. So follow up every 12 hours to 24 hours we do. And in case of fulminant cases, particularly pseudomonas, you can see in fact earlier. And then as the eye improves, you go to 24 to 48 hours follow up. And if it is after 24 hours, if it is stabilized, then you wait. Or if it deteriorates, then you go to the next step. So either you try repeat intravitreal or you can go for the vitrectomy. So what are the indications for vitrectomy? Nowadays, lots of people we do early vitrectomy, but ideal situation where the endophthalmitis vitrectomy study says the vision less than hand movement. In cases of cornea involving endophthalmitis not responding to intravitreal antibiotic, late post-trabeculectomy surgery, fungal and P. acne cases, and also in diabetics, early pars plana vitrectomy may help. So principles of surgery is IOL not removed in most cases nowadays, and anterior chamber maintainer initially we start, then anterior membrane and posterior capsule to be cut, of course, to remove safely as much vitreous as possible, avoid basic scission, strictly vacuuming the exudates over posterior pole. And usually to avoid basic scission, so now we can show you whatever we are telling about this. Started the surgery with anterior chamber maintainer. Next, we cleaned the anterior chamber and removed the membrane over intraocular lens. The surgery proceeded by clearing the anterior vitreous and cutting central posterior capsule. Careful removal of vitreous and membrane continued till the posterior pole was visible. Previously, we used to stop here, but here we forced ahead with careful vacuum cleaning the exudates over. We also clean the peripheral vitreous. Indirect ophthalmoscopy is done. Plaque along with dexamethasone injected. Microincisional 25 gauge and 23 gauge system help us produce less trauma to already inflamed eye, and this is the case where you can see the cornea condition, and it is totally infiltrated and planned for vitrectomy immediately with keratoprosthesis. It's a redness, pain, loss of vision since 4 days, presenting visual acuity was PL only with inaccurate ER. Situation both for the patient and the clinician. The cornea is totally involved and there is absolutely no posterior segment view. Moderate to severe reaction. So keratoprosthesis is the answer of all the queries here. We started with removal of the corneal bud. Okay. We should try to take as big a button as possible so that most of the infected areas will come out. The anterior chamber also cleaned and the membranes removed. What happened with the intraocular lens? In case of severe infections, better to remove the intraocular lens and make it a single chamber. Keratoprosthesis was fixed to the sclera with 4-0 seal. Sclerotomy ports were made and 25 gauge sclerotomy ports gave us definite advantages, as we can see here. In this type of cases, what should be the limit of vitrectomy? One can very well ask the question. We should try to remove as much as possible vitreous. Triamcinolone acetonide was very helpful in inducing posterior vitreous detachment and identifying the membranes so that we could remove them as far as possible. One important point to be noted during closure is to make these sclerotomy ports totally secure. And keratoprosthesis and the cornea, the host cornea is slowly fastened, as you can see here. Donor cornea was already processed and vancomycin and ceftazidime were injected. Balanced solution was used intraocularly to make the eyeball firm. The result wise, we can see the posterior segment got cleared pretty well. Anterior segment showed the cornea clearing and the decreasing inflammation. Keratoprosthesis situation both. So these are the doses of the injections which we usually use. The vancomycin and ceftazidime are the standard we use till the culture report comes. And then amikacin rarely used nowadays. We use the amphotericin and the voriconazole also in case of fungus. Then also we use moxifloxacin and cefuroxime also, and of course injection dexamethasone. Those are the doses. Thank you for your patience here.